We've got a number of copies of this Health Partnership Scheme Impact Report, which we produced just a few months ago, and it goes into some detail. The other piece we have is a report we did last year called In Our Mutual Interest. And really, one of the aspects that we haven't really talked about partnerships yet is the reciprocal benefit there is back to, in our case, the UK health system. The skills that are enhanced for the volunteers who go out and work on some of the projects. And again, the principal author of this particular piece of work is my colleague Graham, who's trying very hard to keep a low profile, but could you please not allow him to do that and go and swamp him and ask him for a copy of this later on? And also just engage him in conversation, because he has some very interesting insights as THET's policy manager. So I've only got a few minutes to talk about this evidence piece and this aspect of our work. And one of the issues around promoting this partnership model is that it's unconventional. And I think it's fair to say that in the UK, the drive for establishing a formal programme funded by DFID, to the extent that it was, as I said, around £33 million, was and probably still is political. One of the attractive aspects of the Health Partnership Scheme, which I described earlier, is that it engages UK health professionals in activities which have the potential to develop the health workforce in low and middle income settings. And you might appreciate that in the current state of affairs in the UK, with our Brexit plans and leaving the EU and so on, that increasingly one of the political aspirations is to make sure that the UK still is seen as having a place on the global stage. And so being able to offer expertise from the UK health sector on a voluntary basis, or almost at no cost to the UK, is an attractive political statement. And so I'm not saying that's all that underpins it by any means, but it is certainly a factor. I do remember that at the beginning of the programme 6 years ago, there were some in DFID who were quite sceptical about this approach. I think one of the health advisors said, but we don't do international development this way. So we have worked alongside DFID and the DFID staff for the past 6-7 years to actually see quite a sea change in the opinions of what I call the development conservatives. So the unconventional approach clearly demands evidence of success. And we have consistently scored highly in our annual performance reviews with DFID, but that alone is not enough. Of course, with THET's 30 years of experience in working in this field, we were sure that the model works, but what we needed was the ability to collect data on a large scale. And that was what the Health Partnership Scheme enabled us to do through funding of around 180 different projects. And what I can say is we have seen evidence of improved access to health services. We have seen improved and sustained health worker performance. We have seen systemic change in some instances. But of course, our evidence counts for little, really. So in 2016, DFID commissioned an independent evaluation, which I referred to earlier. And it was big, it was expensive, and it was challenging. And I remember sitting at my desk on one day halfway through the evaluation process thinking, what if we got it wrong? What if this really doesn't work? And there is that moment when you're in the middle of a big evaluation where you've kind of entrusted people, consultants who you hope have grasped what it's all about. But there is that moment when you think, what if it didn't quite work out the way we thought it did? And that would have been our credibility blown for some years. Thankfully, as you'll have seen earlier, the evaluation report, which is also available on our website if you want to look at it, was unequivocal in its headline that the approach does bring about lasting, sustainable change. Of course, the evaluation isn't glowing all of the way through, and we've been able to address some issues, particularly around the partnership approach and its contribution to health system strengthening on a wider basis, and access for marginalised groups. We've been able to address some of those issues in our latest round of grants, which we've just finalised. But I suppose the greatest confirmation of DFID's belief in the approach is the announcement at THET's conference a couple of weeks ago by a DFID minister that there is going to be a new multi-million-pound programme which is scheduled to start in 2019. So the UK experience aside, we still need more evidence to support the model. And that's why I'm really pleased with the work we're doing alongside the European ESTHER Alliance, working with others across Europe to apply rigorous evaluation metrics to the model. This is a model that can bring significant change. We know that, but we need to know it more. So I'll stop there, and I think we can move on to some practical outworking. Thank you.